Good afternoon. Welcome to the National Combined Grand Round on COVID-19 being held by the All India Institute of Medical Sciences, New Delhi, in collaboration with Niti Aayog. Because of a little bit of a technical glitch, we're a little late today, but we are discussing a very, very important topic. I'd like to start by wishing the panelists, the speakers, and all the audience that have logged in a very, very happy and healthy new year. I'm sure 2021 will bring in a lot of change and hope as compared to 2020. With the start of the new year, there has been a lot of good news. As far as India is concerned, we've had our vaccines now approved by the regulators, and very soon that they will be rolled out, and this will be a big step in trying to really move ahead and control the pandemic. However, there are other causes of concern also. We have a variant which has been reported not only from the United Kingdom, but another one from South Africa. And we know that the viruses do tend to mutate and have some degree of a drift, which causes changes in them, and some of them can be a cause of concern. These variants are a cause of concern because they have made the virus more infectious, and we are seeing the impact in Europe and in the UK. Although India is in a much better situation right now, but there's always a cause of concern that we shouldn't let our guard down and be in that situation. So I think this grand round that we're having today, the first grand of 2021, is very, very important because we're discussing very important issues, and we have probably the topmost people in the country to discuss these issues. And therefore, it's something that will be really a feast as far as education and knowledge is concerned. So I'm really, really happy to introduce the panelists. We have Professor V.K. Paul, who is a professor of pediatrics and member Niti Aayog. Thank you very much, sir, for coming in. This is part of your initiative, so it's great to have you here for your talk. We have Dr. Gagandeep Kang. She is professor of microbiology and vice chair of CEPI and from CMC Vellore. Thank you, Gagandeep, for coming on and taking your time out. Then on my left, I have Dr. Anjan Trika. He's professor of anesthesia and critical care, and he'll be there to answer your questions. And on my right, I have Dr. Arvind Bagga, professor of pediatrics at the All India Institute of Medical Sciences, New Delhi. We also have an individual coming in from New York, and I'm grateful to him because it's early morning there. Dr. Harish Moorjani. He's clinical assistant professor of medicine in New York Medical College, New York, and has been involved with the vaccination there. And we also have Dr. Uma Malhotra, clinical associate professor, University of Washington, Seattle, USA. Thank you, both of you, for joining in at odd hours. And we would really be looking forward to your experience because many of you've been vaccinated, you've been involved in the vaccine trials in the US, and your inputs would be very useful as India starts rolling out its vaccine program. So to set the ball rolling, we'll start with the first talk. This grand round is slightly different. We are not having a case presentation or a case discussion. We're basically having two talks and a personal experience talk by Harish Moorjani, and then we will have questions from the audience. All of those who really want to ask a question, please send it through WhatsApp. The WhatsApp number is given below, 9999692364. So I'll repeat this, 9999692364. And we'll start with the first talk, which is by Professor Gagandeep Kang, and she'll give us a broad overview of mutations. What are they and their impact on diagnosis and vaccine development for COVID-19? Something that all of us are concerned about. So it's over to you, Gagandeep, for your talk. Thank you very much.
Thank you, Randeep. Pleasure to be here, and thank you all very much for inviting me. Can you let me know if you can see my screen?
I think it's coming on. We're waiting for that. Yes, we can now see your screen.
Okay, great. So I've titled the talk Mutations and How They Matter. And what you see here is a picture of the spike glycoprotein and the most recent mutation that we from the UK strain. This is the 501, Y shown in yellow. And what you can see from, sorry about that, from this is a head-on view, and if you look at the side, you see that these mutations are towards the top of the spike protein, approximately where it binds to its ACE2 receptor. So whenever you see a mutation in a region that's going to be responsible for binding, it is a matter of potential concern. So if we look at the virus that we are talking about today, SARS-CoV-2 actually belongs to the Baltimore group 4 of viruses, which are positive strand, single-stranded RNA viruses. And among the viruses, coronavirus is one of the largest viruses that are it's possible for an RNA virus to be. It also has a very, very large genome. But it tends to accumulate mutations at a relatively slow rate compared to other viruses. Usually RNA viruses mutate faster than DNA viruses, but coronaviruses are relatively slow mutators usually, but in this situation we have some unusual things happening. So when we think about mutations, what are mutations? Mutations are essentially changes that happen in the sequence that encodes the viral genome. So these will be changes in the RNA, and these could be additions, they could be deletions, they could be inversions, and these could result in no change at all. They could result in a change in the amino acid. So a synonymous mutation is where the nucleotide changes, but the amino acid does not change. And in non-synonymous mutations, you get changes in the amino acid as well. Mutations can be deleterious or beneficial. Most mutations tend to be deleterious and are removed from the population by selection. Whereas if it is a beneficial mutation or a beneficial combination of mutations, that can be maintained and favored, and in some cases can even be positively selected for as the virus replicates. You can also have situations where viruses can recombine with each other, and this happens for RNA viruses, and that leads to a greater genetic diversity. Now, why do mutations happen? Mutations most often happen because of copying errors or replication errors, but they can also happen because of nucleic acid damage or because of editing of the genetic material by host-encoded proteins or by specialized systems which are called diversity-generating retroelements. Now, the fact that this was an RNA virus led to a very early recognition that we needed to track this virus over time. So WHO established in June of 2020 a virus evolution working group, and the goals of that was to strengthen the mechanisms globally to identify and prioritize what might be relevant mutations, to study their impact related to viral characteristics important for disease, which is virulence and transmission, as well as for the effectiveness of diagnostics, vaccines, and therapeutics. And then the group also looks at what are possible mitigation strategies and how do we study the impact of these mutations, including laboratory experiments and animal experiments. This group has been working for 6 months now and involves a very large international collaboration, and CEPI is obviously part of that. Now, if we look at SARS-CoV-2 variants, even though we seem to be significantly worried now, actually, variants started very early in the one-year history of SARS-CoV-2. We had the D614 gene mutation, which was a mutation in the spike which actually resulted in replacing the initial SARS-CoV-2 strain that had come from China, and within a matter of 5 months, it became the dominant strain that was circulating globally. This was also a strain that had increased transmission, but not severity. In August and September 2020, we had another matter of concern. These were cluster 5 variants that were identified in farmed minks, and essentially the virus went from humans to minks, modified itself in minks, and came back into humans. There were only 12 cases of infections with the cluster 5 variants, but there were concerns that this particular variant may result in reduced virus neutralization in humans, and studies are currently ongoing in the laboratory to determine whether that is the case. We then had what was called variant under investigation and then called variant of concern 2020-1201. It's also called B117 or 501YV1 or the UK variant. This seems to have increased transmission but not necessarily increased severity, and I'll show you data for that. And the South African strain, which is 501YV2. This has rapid increase, it has higher viral load, so it's likely to also result in increased transmission, but this needs confirmation. So why do mutations matter? Can mutations change our ability to detect the virus? Can mutations help the virus to cause more severe disease, spread faster, negate drug or monoclonal antibody therapies, or escape vaccines, resulting in reinfection and disease? So if we look at the UK, it has 23 mutations, of which 17 have resulted in amino acid changes. 13 of these are non-synonymous. There are 4 deletions and 6 synonymous mutations, 5 in the OF1AB and 1 in the M gene. 3 of these mutations have biological significance. Mutation N501Y is one of the 6 key contact residues within the receptor binding domain and seems to be responsible for an increased binding to human ACE2. The spike deletion 6970 has been noticed within many other variants and is also associated with other RBD changes. And mutation P618H is right next to the furin cleavage site, where the viruses cleave as it binds to the receptor to enter the cell. Now, the 6970 mutation is the one that has the most significance for diagnostic tests. Most of the tests are PCR, and fortunately for us, most tests have more than one target. So a mutation in one target to not a lack of diagnosis, but to a target failure. This was seen in the UK with the S gene target failure. It in fact became a diagnostic. This is not something that we were not expecting or did not know. It's already been published before that certain mutations can result in some tests not working anymore. So the more genes you're targeting, the less likely you are to have this effect. So if you look at this graph over here, which shows you how the B117 was increasing over time, you can see that that also paralleled the diagnosis of this strain, because you started to see at one laboratory when you were testing that there were a lot of S dropouts. So S was not being picked up when other genes were being picked up by PCR. So this became a diagnostic, and if you look at this histogram over here, shown in the bluish green color is the pickup of the B117 or the 6970 deletion. And what you can see here is that as in most places, cases went up as this strain went up, and in places where the cases were crashing, you actually saw less of the 6970 deletion. And this is really different areas in the UK where testing and sequencing were happening. So moving to, can the mutation cause more severe disease? Public Health England has just reported a matched cohort study with 1769 people infected with the variant strain and an equal number of controls. Their findings are that there was similar age and gender, similar ethnicity. The variant strain was more likely to be part of a residential cluster than wild-type comparator strain. There was no difference in hospitalization, no difference in deaths, no difference in reinfections, and secondary attack rates seem to be a little bit higher for the variant. Now, can the mutation help the spread of the virus? Well, we know from the growth rate of genomic data that there is an approximately 70% increase. So studying correlations between R values and the detection of the variant seem to suggest an absolute increase in the R somewhere between 0.4 and 0.9. CT values for PCR suggested a decrease in CT value of around 2, indicating a higher viral load. So that was believed to be about 0.5 increase in median log 10 inferred viral load in the new variant. So can the mutation help the spread of the virus? It appears very likely based on both laboratory and clinical data. Now, if we look at the spread of the mutation, and the mutation is shown here in the very bright pink color, you can see that in the United Kingdom, you have started to see that recently. And remember that the size that is covered on the graphs is as a proportion of the strains that have been sequenced. It does not reflect actual numbers. So although Norway has a tiny number of cases, they have had a massive expansion in this variant strain. It's also being seen in increasing numbers in many other countries. Now, this strain is spreading around the world, and if we look at dates and we look at spread over time, you can see that the older strains are seen in Europe and the new strains are spreading in other parts of the world. There is data from GISAID that looks at the first 3 Indian strains that were reported. And what you can see here is that they are 3 different colors, indicating that these were 3 separate introductions in Karnataka, Andhra Pradesh, and in Telangana. Now, moving from that to what does this mean in terms of the immune response? We know already that if you grow a virus in culture in the presence of a monoclonal antibody, you can get mutations that render the virus resistant to that monoclonal antibody. This had already been shown in the lab for many viruses. And most recently, we have just had data that shows that mutants can be generated with the antibodies produced both by Regeneron and by Eli Lilly, indicating that if we want to see these monoclonal antibodies work in people, we will need to ensure that we use a cocktail that is designed appropriately for the regions of the spike protein that it targets. And shown in red are the places where escape is most likely. This escape has also been seen in at least one immunocompromised individual who was infected with SARS-CoV-2. Now, in terms of what we are seeing with the N501Y, the question is is this what happened with SARS-CoV-2? Did it go into an immunocompromised individual? And was that the reason that we have so many mutations in a strain that appear to be significant? And if you look here, you will see the importance of the receptor binding domain. So shown here in this graph is that SARS-CoV-2 has to attach itself to its receptors in order to be able to enter. And the spike protein, which is responsible for that binding to the receptor, on its surface is a protein which is the receptor, which has the receptor binding domain on its surface, and that binds to ACE2. Now, if you look at the receptor binding domain, this actually is a floppy protein attached on a hinge. The RBD receptor binding domain can be up or can be flat or down, and binding is dependent on its conformation. All of the vaccines that we are using are against the receptor binding domain are directed against the pre-fusion spike structure of the virus. And this has been stabilized because it's important to induce neutralizing antibodies to the pre-fusion structure of the spike. Now, the next question is, we know monoclonal antibodies have an issue, but can you actually have a polyclonal also being escaped? And data from last week shows us that SARS-CoV-2 can evolve to also escape a polyclonal immune response. Does this render a vaccine ineffective? We don't actually know this at this time, but it does appear that the strain that we are seeing from South Africa, which has a number of key mutations, including this E4846 in the receptor binding domain, is going to be more of a problem than the UK variant. Now, yesterday there was good news. Pfizer's vaccine induces an immune response that works against the UK variant strain. The strain has been grown in culture, and it has been evaluated with sera from people vaccinated with the Pfizer vaccine, and there is very good neutralization. So this is good news. We know the mRNA vaccines are likely to work against this variant, but we don't know whether it will work against all variants. And then mRNA vaccines can be made very quickly. It's important to remember that if we look at the 1270 amino acids that are in the Pfizer vaccine, the variant actually differs in only 9 of those amino acids. The BioNTech founder, Uga Sahin, has said that a new vaccine could be designed in a day and made in less than 3 months, but it will really be about regulatory processes after that. And then there is not so great news, because all of the data that is being generated from monoclonal antibodies and from the sera of vaccinated people, including people who had plasma therapy, is essentially showing that if a virus is circulating unchecked and vaccination rates are low, or if one dose of a 2-dose vaccine is given, then the probability of mutations is only likely to increase. What does this really mean? It just means that we have a lot to do. We have to do more with surveillance. We have to do more with the use and the monitoring of existing vaccines, and we have to be prepared for the potential that we might need to develop new vaccines as well. So thank you very much for your...
Thank you very much, Professor Gagandeep Kang, for a very comprehensive overview of what mutations is all about, giving us some hope, but also scaring us a little bit that we still may have problems subsequently. So Thank you very much. We'll move on to Professor Paul, who is going to give us an overview as far as India is concerned. Professor Paul will be talking on COVID-19 vaccines in India and our strategies for vaccination. Again, something very, very important and which I think we're all wanting to know about. So I look forward to your talk, sir. Over to Professor Paul.
Can you confirm that my screen is visible?
Yes, we can see your first slide, sir.
Thank you very much, Dr. Guleria. Thank you, colleagues. Thank you, viewers. Thank you, panelists. I will, in the next few minutes, discuss the emerging plan of COVID-19 vaccine implementation in the country. As you may know that by and large, this is the summary that we have two COVID-19 vaccines that have received emergency use authorization. The government has been working with other stakeholders, particularly union government is working with state and UT administrations for preparing an all-out plan to roll out the vaccination at the earliest time. Uh, I like to make a case that our preparations are on track and it is possible to go into implementation reasonably soon in coming days. This is the current pipeline of vaccines in India. There are there are 6 vaccines being in trials on the soil of India. And these are roughly positioned as to the level of their maturity. Serum Institute, Oxford, Covishield vaccine, the Bharat Biotech, ICMR Bharat Biotech Covaxin, and Sputnik 5 vaccine, which is being taken forward by Dr. Reddy's laboratory. Zydus Cadila vaccine, which is entered now phase 3, for which they got the permission recently. Sputnik is moving from 2 to 3, but it has footprint of trials in other countries. And then phase 1, phase 2 coming from Genova and Biological E vaccine. Genova is a mRNA vaccine, and Biological E is an RBD protein vaccine in the early stages. We are hoping that Genova mRNA vaccine would actually be stable at 2 to 8 degrees, and therefore a lot of hope. And they also, between them, they have a significant capacity for ramp up as the time elapses as we move into this part of the pipeline. That's the overall pipeline. Uh, the the decision making with regard to uh, vaccines and vaccine implementation and the policy and the programmatic interface has been driven by two groups, two committees. One was instituted very early in the course of India's pandemic response, way back in early April. This is a task force on research on corona vaccine and other science and technology issues. It focused on developing and putting vaccines to trial in the country. It made an interface with academia and the industry in the early phase, but it also focused on other technologies that were and continue to be of relevance, including the diagnostics and including other technologies. Then in August, a group was constituted called the National Expert Group on Vaccine Administration for COVID-19. Its acronym is NEGVAC. It is a representation from the union government of the concerned ministries, including science ministries, Ministry of Health, Department of Health Research, External Affairs, Finance, and so on, and pharmaceuticals. It also has 5 state government. It also has technical experts and representation of the NTAGI system of the country. And this is the implementation side, and the left one is on the research and development side. These are the two groups that have been steering the process of vaccine development, overseeing the vaccine capabilities, and also now looking at implementation of the vaccine, the rollout of the vaccine. I move to my second point that I wish to emphasize, namely the process of prioritization and the background that. I think that should be known to colleagues on the conference today. Remember, this is a diagram from CDC, came up in the public domain very early in the course of the pandemic. It shows that there is time on the x-axis and there is potential vaccine dose availability on the y-axis. You would see that there will be a situation that the blue line, just follow the blue line from the left to the right. There is a situation when there is no vaccine. And then gradually some vaccine or vaccines become available and the stockpile starts to build up. And then it builds up to a point that we may call a plenty of vaccine point or the optimum availability. And then perhaps a time would come when the vaccine would not even be needed. Now, remember, the challenge for us is that when the vaccine adequacy in terms of stockpile it does not match, the supply does not match the demand, then you have to institute a process of prioritization of population who will get the vaccine. And this is a very fundamental issue for a disease that we are facing today, that there will be potentially many more beneficiaries, the people who should be taking it, potentially, but the supplies are much less and they are building up rather slowly. So in this period lies a challenge of prioritization. On this, WHO provided an early guidance and which actually set the stage in a way for similar approach to prioritization. And what comes through are essentially two fundamental principles. One, you protect the health system. Here is to, let's say, optimize industry, optimize schools, optimize economy, optimize social life. And then the last frontier is that you generate enough herd immunity to extinguish and drive out the virus, and we live happily thereafter. Remember, the last objective can only be met with a very large number of vaccine coverage, which of course would be in a position to develop optimum and solid and lasting herd immunity. Obviously, when you don't have enough doses to go for that level of coverage, then you prioritize, and the first wave of prioritization is what you see here, a general consensus that you save your health system and pandemic response system and you reduce the deaths. And then when you translate this into practice, the WHO's document talks about frontline workers in health and social care settings, and then talks about people who are above the age of 65, who are particularly predisposed to mortality, and those below that age but have serious morbidities that put them at higher risk due to COVID-19 disease. When we look at our data, this is what you see. 80%, specifically 78% of deaths among COVID-19 cases in India occur over the age of 50 years. If you cut it out at 60, then you are looking at 54% of deaths. So above 60, 54% deaths, and above 50 as a whole, you have 78% COVID-19 related mortality. So that's one fundamental fact emerges out of this very simple data. But also equally importantly, we know that more than 2/3, close to 70% individuals who die have serious comorbidities. And these are comorbidities related to renal conditions, diabetes, heart, and so on. And that's the second fact that emerges. Now that then takes us to the following. That in summary, 80% deaths among cases above 50% and 67 odd percent have comorbidity. But you also notice that if you cut off at 50 years, above 50 years that is, then we know from the global burden of disease data of India and looking at chronic morbidities that I was referring to, then 70% of comorbidities are among people above 50 years of age. So when you combine this, then people above the age of 50 emerge as a distinct potential priority group because you capture 80% of mortality and you capture 70% of comorbidities. That's what led the group, NECVAC, to propose what we are going to show as priority group. So we said, let this be the aspiration. And that's how it flows. We thought if India could cover the following groups, we would meet the priority objective of vaccinating India. Uh, this is with the purpose of protecting the health system and the pandemic response system, and also to reduce mortality in a very big way. So this is how these priorities emerge, and they amount to a total of 30 crore people, which is 300 million individuals. Healthcare workers, 10 million, frontline workers, 20 million, people above the age of 50 years, 260 million, and people below 50 but having serious morbidities, we positioned at 10 million. This is the priority group that the Indian stakeholders put together as a way forward. You would note that primarily you are focusing your attention to people about 50 years of age. This number, by the way, is aspirational. This is not a small number. This is more than the population of several countries put together, perhaps. So this is the first wave of immunization that the country is aiming toward, and we believe we would have enough stockpile of vaccine available to cater to this in about 7 to 8 months. Well, our prioritization grouping in principle is no different from what other countries have done. I showed you what WHO proposed, but you also look at other countries. Essentially, you're playing with this. You have UK, for example, has done much more nuanced layering of the age criteria because they have a lot of people in old age homes and they are easily identifiable. So they have done more nuancing. They have these records. We don't. And other people have a mix and match of the same thing. So in principle, this is broadly on the lines of the global consensus, but we are being aspirational here. We are going all the way to, in the very first wave, of all people above the age of 50 years. What are the key principles that drive the process of implementation? We look forward to building a system that ensures smooth implementation down the grassroots level. We will use technology effectively and intensively. There will be no compromise as our aspiration for existing health services, including facility-based services, but in particular, national programs and the primary healthcare outreach system. We will use the experience that we have gained from holding national elections as well as universal immunization program. And let me give you some number. Now, universal immunization program, every year we have 650 million doses administered. And we have more than 9 million sessions conducted. Huge experience. Of course, for the current program, it is much less. But nonetheless, we have an experience of great depth and great width and also sustained over many, many years. Also, 81 crore people, that's more than 810 million individuals, have the right to exercise their franchise in national elections, the parliamentary elections, which are implemented in a matter of days in the entire country. So that experience is very handy. That tells us how we can set up a booth for a well-defined activity spread over a day, which is conducted in a very orderly way. People know where to go. People know approximately how long it takes. They stand in a queue. There is no noise. There is no disturbance. All systems function. By the end of the day, that booth, specific to typically about 1,500 adult voters, is open for exercising the voting right. So there's a huge experience. Fundamental SOPs of elections are highly useful to our work, and of course, we would like to see this activity being a people's activity and emphasis on what we call in what we call as Janandolan, so that people are involved. There is volunteerism in terms of organizing these sessions. They are educated and their people are on board. Guidelines are available in the digital space, developed with consultations, with deep consultations with the experts, but more so with the state government, because ultimately it is the governments of the state and the union territory administration that would implement the program. So these guidelines talk about governance mechanism, convergence, training, the platform, the digital platform, how to monitor the adverse effects following immunization, monitoring, supervision, how to conduct a session, cold chain, communication, social mobilization. So it is a compilation of the SOPs that's already now available in public domain, as well as has been shared and has been used. We are looking at for the priority task, we are looking at in the first of this wave, we are looking at healthcare workers and frontline workers. These are 30 million. So you are looking at about 60 million doses with some buffer stock, 66 million doses. For this and beyond, cold chain resources are built up. We are looking at 29,000 cold chain points. We are looking at 61 consignee points in the country. Sufficient quantity of syringes and needles are available all the way for the next 6 months and beyond. And there have been streamlined mechanisms for priority transport of the vaccines with air, by other connectivities, and so on. So this part has been readied already. Our events following immunization protocol has been developed by the National Technical Advisory Group on Immunization with their help, and this will be mainstreamed into the IT platform, but also it will follow other SOPs. This is the governance mechanism. You're looking at the expert group, the NECVAC, being on top in terms of overall steering. State levels have steering groups analogous to NECVAC in a way. Then they have an action force, the task force, and there is a control room. District level has a district task force, and for urban area, specific task forces for urban area and a district control room. And then we at the block level have a block level task force and a block level control room. So and this whole governance mechanism has been set up throughout the country already. There is a distinct effort to follow a communication strategy which educates people, educates media and everybody else, which builds on vaccine confidence. It addresses vaccine hesitancy. It promotes vaccine eagerness, promotes COVID appropriate behavior, and also it believes and ensures in passing on the right information. So there is this communication framework which we believe is extremely important, and this has again been developed in partnership with the state governments. I'd like to show you 2 or 3 slides on the digital platform, which will be the backbone of the vaccine delivery program. Let me see. All right. Okay. So this is, we call this platform as co-win with W, winning together or winning the COVID war, so to say. It builds on something which existed earlier in a rudimentary form called Win with We, which was basically a logistics management IT platform, which has now evolved into a much bigger, much more comprehensive co-win platform. Well, it has multiple elements, but it uses a mobile app to tell you about your appointment for the vaccine on a given day. It uses that app for us to register. One part of this is tagged to the cold chain system, and with each cold chain consignment, there is a temperature logger in the refrigerated van traveling between Karnal and Delhi, for example, and that is available to be tracked on this platform. Then there is a dashboard, there are other applications, and it makes interface with the beneficiary. I'll explain this a little bit more as we move on. Here is how it will work. Manufacturer ships the vaccine through air transport to large vaccine storage hubs, which are cold storage hubs, which have been augmented to accommodate COVID-19 vaccines. From there, it moves through refrigerated vans to the lower level stores, and then on to district, and then on to the facilities in the urban or rural areas. This is the lineup that we had already as a part of the original IT platform. Onto this is now built how to conduct a session, let's say at a sub-center or in an urban private clinic, let's say, how individuals would get registration done or their data would be visible on the platform, how a session is allocated to the people who are going to conduct it, how individuals will receive their information about the vaccine opportunity, vaccine appointment, which day, where, then interface with the beneficiaries. There is a provision for repeated SMSs, something like 6 or 7 SMSs from time to time in 11 different languages. You will register and you therefore generate a unique health ID. There will be a certificate given to you at the end of the vaccine session for the next appointment, but you get your certificate of 1 dose and then 2 doses. And then it's also linked to the AEFI reporting, which was our original SafeVac IT system, which has also been merged. So this shows you the journey through which the IT system will take the implementation through. Looking at in a different way, the IT platform, which we believe is a global public good, will not only be used, made in India, not only to be used in India, but this will be offered to other countries to use as a ready-made IT platform. It has Aadhaar identification, AFIs, SMSs in 12 languages, vaccination certificate. It is linked to a DigiLocker. It connects you to helpline, and it has functions. Some of them I have mentioned. It also has a helpline for people who are running the IT platform in different states and districts. If they have any difficulty, they reach out through the system to a master hub where problem solving would happen. It has chatbot, it has natural language processing, and of course, dry runs have been taken place. Field testing of the entire system, including the IT platform, has been conducted in 7 districts in 4 states on end of December. And now, few days ago, it has been carried out in 286 locations in 125 districts, and now another round of dry run will take place. This is just to say that the what was done as a part of the field rollout dry run. This is the more recent dry run, 286 sessions in 125 districts. Physical verification of the sites, teams, SOPs, protocols tested, and based on this protocol and based on the feedback of this extensive exercise, improvements have been made, and there would be, if need be, other corrections done in due course. To summarize, let you know that the preparations for a rollout are in full swing and complete and at a level of actual operation. I'm happy to let you know that by today, 7.8 million healthcare workers have registered or have been placed on the listing on this platform. 7.8 million is 78 lakhs and 200,000 frontline workers. So 8 million individuals have been lined up on this platform already, and the next wave of enrollment is going on as we speak. I'm happy to also let you know that 200,000 vaccination centers have been envisaged, and more than 200,000, plus vaccinators have been identified. It is possible for us to aspire to cover these 300 million beneficiaries over the next 7 to 8 months, and we believe this major effort, which could turn out to be the largest COVID-19 vaccination program of the world eventually, would have a very significant effect on mitigating the impact of COVID-19 and hopefully extinguishing the pandemic, not only in India, but also in the world.
Thank you, sir. Thank you very much for a very comprehensive cover on, for comprehensively covering India's plan and strategy for vaccination. It's a huge task considering our population and the diversity of our nation, and there have been questions which we'll address later on. We'll move on to the final talk, which is basically by Dr. Harish Moorjani, who's clinical assistant professor of medicine from the New York Medical College, New York, and he'll be talking on his personal experience with COVID-19 vaccine. So it's over to you, Dr. Harish Moorjani. You're mute. We can't hear you. Just give us a minute. Can you hear us?
The table clear karo.
We're not able to hear you. Just check from your side that you have not muted. We'll check from here that we have not muted. I think you need to increase your volume. The volume that you have is very low, so it's not being able to. Input volume. Still not able to hear you. Let's work some. We'll just give it another half a minute. Otherwise, we'll go for questions and we'll sort this out and have you back. So I think while we resolve this, we'll take some questions because there's been a lot of questions which have come in, and I'll start with Dr. Gagandeep Kang, and this is basically regarding you covered this also, but one of the doctors has written that in UK there's been now an increased duration between the first and second dose as far as the vaccination is concerned. From 28 days has become 12 weeks now. Will that have any effect as far as mutation is concerned, or will this lead to vaccine escape? So what are your comments on this? And this is there are two questions. Another person has also asked a question. It's a similar question, saying that the Oxford study claims that the antibodies will develop 14 days after the second dose. So after the first dose, how much protection do we have till we get the second dose of the vaccine? Because this has implications for many countries in terms of vaccinating a large number of people just with the first dose, and thereby thinking of some protection but having a challenge of mutations emerging and not having full protection. So your comments on this?
So this is a very, very complicated question. So the reason that well, let's start with the analysis that the JCVI did of the AstraZeneca trial in the UK, based on which the UK has decided to extend the interval between the doses. Essentially, what has decided that this is an approach that they can afford to take. There is also some biological data that is available from people who have worked with adenovirus vectors in the development of HIV vaccines, where they believe that 4 weeks is actually too short an interval and you should be trying to prolong the interval so that the second dose of vaccine gives you better memory. First dose for an immediate protective response, second dose for memory. On the other hand, there are also immunologists who work on RNA viruses who say that what you're setting yourself up by prolonging this interval, you're going to create more mutants. And the reason that they say that is that for example, for the Pfizer vaccine, it looks like after the first dose, you get a low-level neutralizing antibody response, and then with the second dose, you get a much higher neutralizing antibody response. So I think there needs to be a much more careful appreciation of what the platforms are and what the data are for each of the platforms that we are planning to use if we want to modify schedules in any way.
So if I may just probe a little bit, what is your recommendation? Should we go for a, because obviously it would mean one would have more doses available quickly to vaccinate a larger number of our population, but you're always worried about the risk that you have. So I'm just sort of asking you from that point of view.
I think it depends on the vaccine, and with the AstraZeneca vaccine, I'd be more inclined to prolong the interval because of the data that we have from the half dose, full dose study. So I also think that we need clinical trials before we make any decisions on on changing what has already been done. I hope these trials will be done.
Thank you very much. We'll move on to the next question, which has also come from a doctor, where I think this is for Professor Paul. What are the protocols in place for managing adverse reactions from vaccines? I think there is some concern that this physician has. So, sir, any comments from your side? I think Dr. Paul is frozen over. I think Dr. Paul will get the connection. Maybe then I can ask Dr. Uma Malhotra, she's a clinical associate professor, University of Washington, to just give her experiences and what she would really like to tell us as far as the vaccine program in the US is concerned.
Okay, so I'm here. Okay, so anyways, well, thank you, Professor Guleria, and thank you to all the speakers. It's been a very informative session. And we in the US here started our rollout about the third week in December. And I will say, certainly, it felt like as a global community, we'd been, consumed by the pandemic. And now it really felt like that the community had really come together to bring a vaccine within a short period of time, and so which is clearly very exciting. So we're clearly in the US not at target in terms of where we want to be in terms of dosage delivery. So our goal had been 20 million doses by end of 2020, and we were at about 4 million doses at that time. So I think the fact that some countries are a little behind in terms of the vaccine becoming available, but it's really a good opportunity to make sure that our rollout plans are coming together. And it was, really heartening to see, hear from Professor Paul how, all the practice runs and how the infrastructure is coming together. And, I think couple things from my experience at our own institution uh, to keep in mind would be, uh, as we make the process efficient, we also have to make sure that we don't, cause outbreaks from from people just congregating. So I'm just thinking about a lot of people coming together in India also for the vaccination, and making sure that we're able to maintain that social distance between individuals while they're waiting for the vaccine as well as after the vaccination, because they will be sitting waiting for a half hour. So those were some things that come to mind. And also for folks to remember that uh, it's only a layer of protection. So our vaccine, we're getting the vaccine, and clearly we won't have sufficient protection even after the second dose. But folks to remember that we still need to continue with other measures, social distancing and avoiding crowds, and masking. And I think another thing to point out would be to what we have learned from these vaccine trials is that we're preventing symptomatic infections. So we have not shown that we're preventing asymptomatic infections. So we may be gaining protection, but we may still be able to, transmit to others. We don't have that data. So making the community aware of that.
Thank you very much. I think you've raised two very important points. One is that vaccination doesn't give you freedom to really not have COVID appropriate behavior. That still becomes very important, because you may not get the disease, but you may still have mild infection and you may be infectious. So we need more data in terms of asymptomatic infection and mild infection, which would still make you infectious. So COVID appropriate behavior is going to be here for quite some time. Um, there is one question which I'll ask Professor Gagandeep Kang. What is the difference in the antibodies produced by vaccination and that produced by infection? Are they the same or are they different, and which would be better?
So that's again an interesting question, because most of, in vaccination, you're going to produce antibodies to whichever antigens you've given, and in infection, you will produce antibodies to many parts of the virus. Now, which is better really depends. It certainly is the case that we've seen for other RNA viruses that if you have a natural infection first and then you take a vaccine, it boosts your immune response. The amount of antibodies you make, as well as the quality of the antibodies, is different from people who are given protection through vaccination alone. Whether that will be the case for SARS-CoV-2, we'll have to wait and see. In the trials, we will have people who are previously seropositive and people who were not exposed to the virus. And from them, we will get answers to whether a combination protects better than vaccination alone.
That will be a fascinating thing to see whether the vaccination along with past infection gives you protection more than just the vaccination itself. This was another question that a person had asked, which was this basically, that I suffered from COVID-19 in July. Am I protected? And am I protected against the mutant strain? And should I get myself vaccinated? So, Gagandeep, what is your comments on that?
Right now, the evidence that we have from Pfizer is that if you have neutralizing antibodies, you might not be infected by the variant strain. Or at least you might be infected but unlikely to have disease. WHO has just come out with recommendation and said that people who are infected, if they want to delay their vaccination, it should be delayed for a maximum period of 90 days.
Thank you very much. I think Professor Paul is back with us. So the question that had been asked by one of the participants was that what plans do we have in place as far as the adverse effects of the vaccination are concerned, both the short term and long term, as far as the rollout plan is concerned?
So this is at two levels at least. One level is as a part of AEFI surveillance and response. If there is every vaccinee will have to wait at the booth or the vaccine point for about half an hour for any acute reaction, and if so, it will be managed according to a protocol. Then, of course, AEFI surveillance continues, and there'll be ways to track the recipients. That is the normal UIP-driven experience based on the best practices, global best practices, typically for childhood immunization, but built on this would be the protocols for adult vaccination. But also remember, there will be a post-marketing surveillance by the manufacturers, which we also know by the name of phase 4 trial, so to say, where the adverse effects are followed up for a long period of time. So there are at least these two tracks of follow-up of the effects of the vaccine as it moves into the implementation phase. Thank you.
Dr. Harish Moorjani, is your audio working? Yes,
can you hear me
we can
now?
hear you now. Okay,
Oh,
good. So
perfect.
maybe we can have
Okay.
your talk, and then there are a lot of questions which have come up, so I'll collate them while you give your talk. So over to you.
All right. Can you see this presentation?
Not as yet.
So I said share screen.
I think it's just coming on.
Is it on now?
Yes, we're getting it here. It's coming.
Are you getting? Okay, excellent. All right, so it's easy for me because I'm following Dr. He actually outlined all the issues related to the vaccine rollout in India. In the US, it's the same. I'm not going to focus on the vaccine trials, which actually were picture perfect. The way the trials were designed and done in the United States was just remarkable. The feedback we got from people who were enrolled as patients and people who were actually involved in doing the clinical trials, physicians, providers, nurses, and the entire administrative staff. The feedback from them was absolutely phenomenal. It was a picture perfect vaccine development program. It will go down in history as the fastest vaccine development of all time. And I think that's important to remember. And then adapting the mRNA platform, which had previously failed in other infectious diseases, to adapt it to this COVID-19 development was absolutely remarkable. So the science behind it is phenomenal. The development of the vaccine was phenomenal. I was involved in it. It was such a rewarding aspect of this whole thing at a time when we were under tremendous stress. And then it was the rollout of it, which we have stumbled upon. It was initially controlled by the federal government and then handed over to the state and then to the local distribution sites. And just like in India, we have prioritization for dealing with the pandemic. Healthcare workers, we saw that the long-term care facilities, nursing homes, where this virus was sort of developing and spreading both to the workers and then to the hospitals. So we prioritize that just like you have. I'm not going to spend too much time on it, but the actual vaccine distribution was a decision of every state. So we have 50 states, and just like in India, just like Dr. Paul eloquently pointed out, phase 1, phase 2, phase 3, and we are now thinking about phase 3. We are going to get to phase 3, we know that, where you have to then significantly improve the uptake by people who are reluctant to take this vaccine. In order to develop herd immunity, we need 80-85% coverage. So how are you going to get people who don't want to take this vaccine? How are you going to get the buy-in? And that was important. So vaccine provider enrollment, we have this through the CDC. It was controlled by the CDC. That went well. And then tracking vaccine administration, just like you have the digital footprint in India, we have our vaccine administration and management system that was designed by Deloitte and Touche. An excellent program. It interfaces with our electronic medical record. Didn't have any problems there. The problems occurred in vaccine, and not even in the vaccine delivery. The vaccine delivery from the CDC and the cold chain worked beautifully, got to the various sites where it was supposed to go. And then once the vaccine is delivered to an end user, an immunization clinic or a hospital, that cannot be redistributed, so it has to be used there. That has certain implications at local issues, minor issues though. In the bigger picture, it worked fine. The federal government was going to give us and has given us all the ancillary supplies. So there's no cost to us except for maybe some sharps containers, gloves, and bandages, which we already have in our clinics and in our hospitals. And McKesson was targeted as the institute, as the organization in charge of this distribution, and they've done a pretty good job. So all this went very well. Open system is in place through Medicare, and it is universally covered. So that was not an issue. It's not, you can't make money giving this vaccine, but it is enough reimbursement that it covers the cost of the nurse and the vaccine administration, even for private clinics. Where it went wrong, and I'm going to play this little clip, a 2-minute clip, which will actually share with you the entire problem of the vaccine rollout from the cold storage to the arm. So let me see if I can play this. I'll play it in a minute. Let me get out of this and we get that. Why it's not playing there. Let's see if I can play this one here. Here we go.
You need to increase the volume.
Okay.
Here are the numbers. 40% said they'd get the vaccine as soon as possible. 44% said they would prefer.
The volume is not there right now.
Oh.
I think that is frozen. For your video, the volume seems to not be there.
Yeah, I don't know why that's not.
The left, down, the right bottom volume.
Let's see if I can play it from here. I'm not being able to. Anyway, let's just move on to the next slide. I'll explain. So what's happening in this country is, of course, that the media and politics comes into play. And so this is an article from New York Times that talks about Dr. Wafa Al-Sadr, who I know very well. You know, she's talking about the nitty-gritty of how you get it from the freezer to the arm as quick as possible is where we stumbled big time. You know, we were supposed to have 20 million people vaccinated, as you heard. We only got 2.8 million, as far as I know, from the CDC numbers. And that's pretty pitiful because we need to get this vaccine rolled out as fast as possible. It's sitting in cold storage. It is not being delivered to the arms. And this is because, you know, the federal government is blaming the state government is blaming the local government is blaming the state government. There's all kinds of politics going on, and that's unfortunate. You know, we did not do a rollout test. We did not put enough money into the infrastructure that needs to go into administering vaccines. We leveraged the hospitals for mass vaccinations, and they've never been in the business of mass vaccinations. We should have leveraged our existing immunization clinics. We have 12,000 immunization clinics in this country. And even if they gave 50 shots a day each, which is easy to do, we would have 600,000 shots going out every day. But we didn't do that. We chose to use the hospitals, which was the wrong thing. And then because I work in prisons, we realized very early on in April and May that the prisons, the incarcerated population was getting hit very hard. And that has implications, financial implications for the state budgets, and has criminal implications for the quality of life in society. And we saw, like, for example, now in Massachusetts and now in New York, I'm happy to report that we've moved the prison population up into priority level for immunizations. We are hopefully going to start immunizing the correctional population this week. Hopefully later this week, either today, tomorrow, or day after, we are going to start so that we can prevent prisons from closing down and releasing criminal elements into society. So these are some of the implications of this vaccine rollout that I have experienced personally. I've gotten the vaccine. It was an easy, simple, straightforward procedure. The hospitals did a great job of immunizing their healthcare workers. Apart from that, let me just stop sharing here. The vaccines in our clinic to give out, but we have not yet received it. Hopefully today, so we can start rolling out. We can give about 25 shots a day in my personal office and as a travel clinic. We can do that. So that's the kind of stuff that needs to be, we need to leverage our existing infrastructure instead of the way the political bickering is going on, which is causing this rollout to be delayed.
Okay, thank you very much. I can see the challenges that we have across the globe as far as rolling out the vaccine is concerned.
Yeah.
We'll take some more questions.
Yeah.
Thank you very much, Dr. Harish Moorjani. This is a question which I'll ask my panelists sitting on my left and right. One of the doctors has said that I've been taking hydroxychloroquine and ivermectin weekly as prophylaxis. Should I stop that before vaccination, or is that to be continued? So anything that you would like to say, Dr. Bagga?
The efficacy of these drugs is still not very clear, and clearly there is so much data now on hydroxychloroquine that seems to suggest that perhaps the drug in a controlled manner is not really effective. I know even ivermectin is being used as a prophylaxis, but again, the data on ivermectin is again not there. So, but having said that, I see no reason why you can't take the vaccine once it's available, even if you are on prophylaxis. And maybe you can probably have the courage to perhaps, and the wisdom to perhaps stop prophylaxis after after you get the vaccine. Yeah.
Would like to say anything?
Well, I have a different take on that. We all knew that there was not enough data for both the drugs, and there were people who continued to take it because of standard guidelines or whatever you may say. And then once the vaccination takes place, and now we have data that once you are vaccinated for X number of days, your antibodies are not good enough. So people who are taking it, they could really volunteer to go on taking it, and then maybe we could have a database regarding them also, because at the first time they took it when there was not enough of numbers to prove that it really worked.
Thank you. I have two questions which I'll ask Professor Paul. One is basically, which vaccine will we as healthcare workers get in phase 1? And the second question is by a medical student. He says, I'm a medical student and I go to the hospital to attend bedsides. Will I also be vaccinated in the first phase of the vaccine?
The answer to the first question is that these details are being worked out at this very time in a way. It will be communicated very soon. And the answer to the second question is that you are a healthcare worker, my friend. You will get the vaccine. Tell the place where you are working that they should put you in the list. And if they don't put, write to Dr. Guleria or write to me. We'll take care. Thank you.
Thank you very much. So it's more a reassurance to you that vaccination will be provided to you. So this is another interesting question which one of the participants from AIIMS has put in. I have participated in the vaccine trial, in the phase 3 vaccine trial as a volunteer at the All India Institute of Medical Sciences. Do I require the vaccine again? The problem is that we don't know whether this person was in the placebo arm or was in the vaccine arm. So what would this person do? This person is already part of the trial, which is still ongoing. Dr. Gagandeep, Dr. Paul, and maybe people from the US, what is their experience as far as such a situation is concerned? Because it is an ethical dilemma. So,
It's a tricky one with the trial still ongoing. I mean, certainly here, once the trials are over, then people know, who got the placebo, and they're given a high priority for the vaccine. But I think in this situation, while they're still in the vaccine trial, I think it'll hamper the analyses, right, if they proceeded with getting a vaccine outside the trial. So my speculation would be that they, for the sake of the sanctity of the trial that they're in, and hopefully the trial will be over soon, and then they can, if they got a placebo, then they could move on to getting a vaccine outside the trial.
first phase of the vaccination, and they have a higher risk of getting the infection because they are healthcare workers. So whether it's ethically right to really continue with that. Dr. Gagandeep, your comments?
True, I hear you. Yeah.
So I think one of the things to remember about informed consent in clinical trials is the participant has the right to leave at any time.
Yeah.
And if the participant chooses to leave the trial and then decides that they want to go ahead and get a vaccine, there is no reason why they should be denied that.
Okay, any other comments from Dr. Moorjani? What are your views on this? It's an interesting question. So your volume, we need to get your volume back. I'll then address another question, which is to Professor Paul. There is developing vaccine hesitancy. How can trust deficiency be built in our own population? What is your suggestion? What can be done?
Well, I think we have to lead as health professionals in communicating the right messages, science-driven messages, and we must have faith in the decisions of the government that vaccines that are being rolled out are in the larger public health interest as well as individual interest, and this is a responsibility that they should exercise in the spirit of your personal health as well as the societal cause. I would just say that this is the starting of the conversation, and we are dealing with vaccines that should be able to address the problem of pandemic impact in a significant way. And therefore, I would appeal with folded hand that please take the vaccine when it comes to you.
Not only we should, I think, in very ways be the sort of champions for promoting vaccine use as far as healthcare professionals are concerned, because we more than anyone else understand how useful and how important it is for not only saving lives and decreasing the number of cases, but getting lots of things back on track, including the economy, children going back to school, and a lot of other educational activities. A lot of academic work has suffered a lot, even in medical schools, for the last 1 year, and the only way out would be to have a very aggressive and proactive vaccination program. So I think this is something that we need to develop regularly. There's one tricky question, so I'm going to ask, maybe I'll start with Dr. Paul and then both of the panelists on my left and right. If both vaccines were available, which would you take? This is one question which one of the doctors have asked.
Well, I answered this in the press conference yesterday. I will take whatever is allotted to me by the health department of my state. I will take that. Absolutely, without any hesitation, and I am willing to take it in public, whichever vaccine is tossed up. And if I was to exercise an individual choice, being an academic, I will go for well, I have a preference for the vaccine that is my institution, AIIMS, is testing. Thank you.
Thank you, sir.
Yes,
And
I
then-
think Dr. Paul has rightly said what we need to follow. Let's have faith in our government. Let's have faith in our government policies. And I can assure you, I'll take the one which Dr. Paul takes, and Dr. Paul would take the one which the institute gives, and that would mean Dr. Guleria takes. So at least I will take it. It's simple. Let's have faith in our system.
I totally agree, Dr.
So,
Arvind.
so I'll agree with with both the speakers, and we would, think that both the vaccines, and we are quite okay with either of the vaccines, and I think any vaccine that comes to the institution would be acceptable.
Okay, this is one question which I'll ask Dr. Bagga again, that this is regarding vaccines which are already being given. There are some patients who are already being advised the flu vaccine and the pneumococcal vaccine. Can this be given simultaneously, or does there have to be a gap? And if so, how big a gap there should be between the influenza vaccine and Prevnar? That's what is the question.
I think our general rule has been, that either you take the vaccines together or you have a 1 month gap. Now, I don't know whether there is enough data on either of these vaccines or on the Pfizer vaccine to say that, but maybe Gagandeep can tell us more. But we would generally give them, if we have to take, they should either be taken together or there should be a gap of at least 4 weeks. Gagandeep, do you have any comments on this? Maybe you can answer this better.
So, from the WHO recommendation that's coming up, there is advised a 2-week gap between the mRNA vaccine. Right now, WHO is only recommending Pfizer, not even Moderna. So the recommendation is for an mRNA vaccine, please have a 2-week gap.
Thank you. The other question is, this is, I think, for Dr. Paul. When can we expect 4 or 5 vaccines in our country, and that will decrease the number of, increase the number of vaccines available? Dr. Paul has again been frozen. So Gagandeep, would you like to really?
So I think we are doing really well on our vaccine development program. So I anticipate that we should have phase 3 data from Covaxin probably by March or April. We have BioE doing phase 1. They are going to need to go all the way into phase 3. Zydus Cadila is going into phase 3 now. Gamaleya will probably be the next one because they're only doing a restricted trial like AstraZeneca. So I think we will probably have Gamaleya as early as maybe March, April with full data sets. And then we will, I really want to see the Genova vaccine because I think that is new technology and would be really exciting to see how that performs, but it's going to need a full phase 3 trial. And with dropping cases in our country, I'm really hoping that we will get quickly to a correlate of protection, so then phase 3s might not be necessary. We would be able to license on the basis of a correlate and do effectiveness studies after.
That with cases dropping and with vaccine program being rolled out, subsequent trials are going to be challenging. And there's a question that, what do you expect from second generation COVID vaccines? How would they be better as compared to the current vaccines? There are more than 50 vaccine candidates in clinical trials. So what would you expect from them?
Single dose vaccines.
Correct. That would be something which will be ideal. Single dose, more immunogenic, long lasting immunity, I presume. Dr. Moorjani, can you,
the Janssen vaccine
sorry.
The Janssen vaccine which BioE is going to manufacture is intended as a single dose vaccine and is in trials now.
Moorjani, is your audio now working? No, we're still not able to hear you. So there was another question which is basically, I think it's a little bit not from, we can hear you now, Dr. Moorjani. Yep.
Okay, I don't know what the issue is, but anyway, so commenting on whether someone who's a healthcare worker who's in the clinical trials, I actually know two people who were in the clinical trials for the Pfizer vaccine who did not know whether they had got the actual dose or they got placebo. They requested to be unblinded, and Pfizer has made that possible. It turned out one had the vaccine, one had placebo. So the other person, the healthcare worker, a doctor who was enrolled in that trial in placebo, has now gotten the first dose of the actual vaccine. So Pfizer has made that call. I don't know about Moderna. They have not yet officially announced anything, but I suspect it's the same. So again, ethical issues involved there, but healthcare workers, I think, are an exception. I'm not sure about anybody else because we are in a situation in Los Angeles. You may have heard there is a complete catastrophe of healthcare system. It's breaking down. It's at breaking point where people are being treated in parking lots because we don't have healthcare workers available. So, you have to look at an individual situation in a local setting as to how you're going to design all these situations in a pandemic situation where there is, big problems going on, issues going on. So local decisions have to be made along with national decisions and worldwide decisions. The issue of future, I think the J&J vaccine is a one-dose vaccine. And, it depends. My feeling about vaccines is that you look at neutralizing antibody, and that's one aspect. But we have not talked about the cytotoxic T cell response and the helper cell response, so the cellular immunity, the helper and the killer cell, is probably going to determine in future what vaccine we are going to come out with for this COVID-19 and how this virus evolves and how we change that mRNA and how it generates cytotoxic T cell responses is, I think, what is going to determine in future what vaccine we prefer and which is going to be the dominant vaccine. So clearly new technologies, mRNA technology is going to be probably the dominant vaccine platform for COVID-19. That's my anticipation.
Which is for Dr. Bagga and for Gagandeep. Vaccination in antenatal women and or postpartum women, is it safe or not? And what about vaccination in married women who are planning a family? So Dr. Bagga has said that Gagandeep can answer it first. Okay. Challenging question.
So there is a difference of opinion. The ACIP, the American Committee for Immunization Practices, has said that you should discuss it with the pregnant woman and let her make up her mind. But the two mRNA vaccines could potentially be used. I think the situation would be a little bit different with a viral vectored vaccine or any live vaccine. The WHO, on the other hand, has said that there are currently no safety data from pregnant women, and therefore they advise against the use of vaccines in pregnant women. Women who are planning to conceive, get the vaccine and then conceive, if you can manage that.
Okay, that's Dr. Bagga, anything you'd like to add?
No, I think there's very limited data, so I really didn't have anything else to add to what Gagandeep just said, But there would be issues with certain vaccines and pregnancies, so I think there would be a certain degree of caution taking the vaccines during pregnancy, especially I would say both in the first as well as the third trimester.
Okay, even for H1N1, initially it was said that you do a risk-benefit analysis, and based on that, if you find that the benefits are much more than the risk, then you could advise the vaccination. Dr. Uma Malhotra, you wanted to say something?
Yeah, I wanted to just add on that at our own institution, as we are rolling out the mRNA vaccines, the question is coming up a lot, is among the nurses and physicians who may be pregnant about whether to, take the vaccine or not. But so certainly in those people, we ask what you just mentioned, the risk benefit analysis. They're certainly, front front care, primary, they're getting exposed to the virus as well. So there's the risk for, getting infected with the virus while being pregnant versus, getting the vaccine. So certainly with the mRNA vaccine, it seems like it could be, quite a reasonable choice. and many of them are proceeding with taking the vaccine.
One more question, which is from another doctor. He says, my antibody titers are high. Can I postpone taking the vaccine? Dr. Gagandeep, your comments on that.
So, as I mentioned previously, WHO has said don't don't defer the vaccine forever. But in a time of limited supply, if you would like to, then you can defer the vaccine for a few months.
And this is another question which is interesting, so I'll ask this to you. He says, if I had both vaccines available, the mRNA and the attenuated, would taking both of them give me better protection?
So, in fact, the UK is planning to find out, because they are saying that they are not going to, they're recommending 2 doses of vaccine, but essentially saying you take whichever doses you are assigned to get. So it might be Pfizer and it might be AstraZeneca. And they are also planning effectiveness studies that will look at impact of vaccines with a mixed schedule as well as with 2 doses of the same vaccine. So we will find out from them. They're really being quite adventurous when it comes to the use of these vaccines.
I think so. I'm looking at how conservative people in UK are considered to be. They're being pretty adventurous. They started off with trying herd immunity in the beginning of the pandemic and not believing in lockdowns and kept schools open. And now they're trying with different vaccine schedules and mixing vaccines. So I find it pretty fascinating that they're looking at a lot of things. I don't know what the science behind it is, but it's an interesting issue. Any such things being planned in the US, Dr. Moorjani?
So no, we are very much data driven here. The FDA has come out and very clearly said that we are not going to do this mix and match. The data is not there. It, I think, is risky. I think one of the things we forget is that this virus has an impact on the immune system, the likes of which we have not seen with any other coronavirus or any other virus for that matter. Even HIV has a predictable effect on the immune system, whereas with COVID-19, the modulation of the immune system in the acute illness and what it means for immunity from a natural infection 6 months, 9 months, 12 months down the road, nobody actually knows yet. Studies are being done. So I think we have to understand that I think the vaccine probably offers better immunity as far as a predictable immunity is concerned, both by neutralizing antibodies and certainly with the Pfizer vaccine, we know the cytotoxic T cell responses are very healthy. So I think we are very reasonably assured that the Pfizer mRNA vaccine for the current strain of the virus is probably the way to go. And mixing and matching is probably asking for trouble with a virus which is very smart and can adapt and can change. I would not recommend it, but the British are doing it under what pretext and under what, how they are justifying it is really beyond me. I would not recommend this under any circumstances.
We've actually crossed our time by quite a number of minutes, but I think we started a little late, so we could do that. But before we wind up, I'm going to ask all of you to give your takeaway or take-home comments, especially regarding vaccination and the emerging mutations and what we should do. So I'll start with Dr. Gagandeep Kang. What is your takeaway to the audience? What take-home message would you like to give to them?
I think this virus is one where we are going to need to marry medicine, public health, and science. So the conversations that we need to have with basic scientists, molecular epidemiologists, and clinicians are going to be critical to controlling the pandemic in the future.
Thank you very much, Dr. Moorjani. Your comments, your take-home message.
So I think to get to herd immunity by vaccinations is probably the solution. Whether the vaccine is effective or not and the virus can adapt to it or not remains to be seen. But we need to increase the uptake and the acceptance of the vaccines so that we can get to a semblance of normalcy with this epidemic.
Thank you very much. Dr. Uma Malhotra, your comments, take-home message.
Yeah, yeah. I think one thing as a global community we became lax on was genome analyses. And so I think as we start rolling out the vaccines, we should, as a global scientific community, also keep up with virus genome analysis so we can continue to identify variants that emerge so the vaccines can be, adapted. So I think, that's something that's a huge advantage with the mRNA platform, whereas we heard that the vaccine can be quickly adapted. And again, I think the second issue for us to be able to build herd immunity, I think for us as providers and leaders to model. I'm not a big fan of media, but I think here, at least in the US, I think it's making a big difference where physicians and leaders kind of model getting the vaccines, that inspires confidence in the product in the community.
Thank you very much, Dr. Anjan Trikar.
See, what I would like to make a comment as a carry-home message would be that we as a society in India, we discuss a lot. Everybody discusses everything what happens in the country. Let's not put a lot of politics into it. Let's have faith in our leaders and our persons in, let's say, Dr. Paul or Niti Aayog, and then whatever they bring to us, I'm sure would be the right vaccine, and let us go ahead and vaccinate. And let us be role models and put all discussions to rest, and let's take away all apprehensions which are there in the society if we want the country to come back to normal.
Thank you, Dr. Bagga.
I would echo what Anjan just said, as well as what Gagandeep said. So clearly, we have vaccines, and they are perhaps our best insurance and our best way to achieve herd immunity, as has just been highlighted. So I think that's the way forward. And as of now, again, there should be no real fear that the current vaccines would not be effective for the mutant viruses. Gagandeep just said, that at least for the Pfizer vaccine, this has been shown. And I'm sure there's going to be emerging data even from within our country that would re-emphasize the safety and the efficacy of these vaccines, even as far as the mutant viruses are concerned. So as of now, I would just again reiterate and emphasize, that there should be no hesitancy, and we should be forthcoming in our receiving the vaccines. Thank you.
Thank you very much. I think what we've learned in the last year, 2020, is that this virus is not to be taken lightly. It knows how to fool our own innate immune system and really causes significant infection, not only in the upper airways, but in the lower airways without people being aware of it. A large number of asymptomatic individuals on their CT scan have patches on the X-ray, or on the have patches on the CT scan. Therefore, we must be vigilant. I think the vaccine is going to be a game changer, I think, in many ways. But that doesn't mean that we should let our guard down. Continue to do aggressive surveillance as far as genomic surveillance is concerned, to really be able to pick up any mutation which has significance, whether it be infectiousness or increasing mortality. Continue to be aggressive in the science behind everything. The last year has really got a lot of scientists together, got research at a high level, put research and medicine at the central stage. We need to take that forward. And I think the backbone has to be good quality research, because that's the only way we would be able to really beat this virus. It is going to mutate and change and fight back. So as we roll out the vaccine, we're going to have the virus also trying to respond to that. So thank you very much for logging on and coming on, and especially to our colleagues from the US, Dr. Harish Moorjani and Dr. Uma Malhotra, for coming at odd times, to Dr. Gagandeep Kang for taking all the questions and really helping us out as far as mutations was concerned. Dr. Paul had to leave for a meeting, but I'm really grateful to him also for really laying out the plan as to how the vaccine program is going to be launched in our country. And to my colleagues, Dr. Anjan Trikar and Dr. Bagga, for giving their comments. Thank you very much for this, and all the audience, of course. Thank you very much for logging on to the National Combined Grand Round on COVID-19, being held at the All India Institute of Medical Sciences, New Delhi. Very happy New Year to you once again, and I look forward to seeing you in the next Grand Round. Thanks to all my panelists, Dr. Moorjani, Dr. Malhotra, and Dr. Gagandeep Kang. Thank you very much.
Thank you.